Good morning. Welcome to our clinical epidemiology session on series of critical appraisals. So last week we did an AI checklist on a diagnostic accuracy study using STAR-D AI checklist. So as a continuation of appraising AI-based research publications, we are continuing with the Consort-Ai checklist for a randomized control trial. And I'm thankful to Dr. Elbin, who will be doing the presentation to see if one of the randomized control trials reporting on AI intervention is in accordance with the Consort-Ai checklist. I'll hand over to Dr. Elbin.
Good morning, everyone. Today I'll be talking about Consort-Ai reporting guidelines. So there are various guideline tools available when AI is actually integrated into a clinical study. So we have the STAR-D AI, which evaluates whether there's a diagnostic accuracy uses an AI-based test. There's Tripod AI, there is Tripod LLM, there is Claim, there is Decide AI, there is Spirit AI, there is Consort AI, and there is Cheers AI. So these are all multiple AI tools which provides guidelines on how to use an AI when they are incorporated in a clinical trial. So today I'll be talking about this Consort-Ai, which deals with whether clinical trials are using AI for a randomized control trial. How should they report the study when they finally publish the study? So I'll be talking about Consort-Ai today. So moving on to a case scenario. So you're working in a busy mission hospital in India where the number of inpatients with diabetes is steadily increasing. And many patients experience significant fluctuations in the blood glucose levels, and timely insulin dosage adjustments are often difficult due to limited staffing. So the medical superintendent proposes implementing an AI-based insulin recommendation system to support insulin dosing with the goal of reducing the burden of limited medical staff. So to answer this question, I looked at a study which was published in JAMA in 2025, where they have looked at a real-time AI-assisted insulin titration system for glucose control in patients with type 2 diabetes mellitus. So I am going to see whether they have used an AI-assisted insulin titration system. So I'm going to see whether they have actually followed the Consort-Ai reporting guidelines when they've actually reported the study and published it. So this is the initial Consort 2020-10 guidelines, which includes 25 subgroups. And this is the AI extension which has come recently in 2019, which included 14 more items, which tells when there is an extra AI which also incorporated into the study. We need to make sure that these extra 14 items are also followed. So I'll be talking about both of these. So the first question involves the title and the abstract. So whether they have, in the title, whether they have identified as a randomized control trial and whether they have given a structured summary of the trial design, methods, results, and conclusions. So they have identified as a randomized control trial in the title itself, because the title says it's a real-time AI-assisted insulin titration system for glucose control in diabetes mellitus, and it's a randomized control trial they mentioned. And the AI extension in this says that whether they have indicated that the intervention involves artificial intelligence or machine learning. So they mentioned that it's in a real-time AI-assisted system. So they mentioned it in the title. And even in the abstract also, they mentioned that the artificial intelligence-based system is used for glycemic control in patients with diabetes mellitus. And they've also given a specific abstract with all the objective design, setting, interventions, outcomes, and results. Now, the second part is background and objective, whether they've given a proper scientific background and explanation for the study, and also specific objectives. So their background, which they mentioned in the article, is diabetes, which is poorly controlled, and due to regimen complexity, hypoglycemia risk, and patient heterogeneity, they had a need to evaluate the efficacy and safety of an insulin dosage titration system, which was given as an objective by them. So they have tried using a AI-based insulin delivery recommendation system, which is compared with the senior physicians in glucose control in type 2 diabetic patients with subcutaneous insulin injection. And their hypothesis was this AI-based insulin delivery system will be non-inferior to the patient's insulin control titrated by the senior physicians. And this hypothesis, they had told that the outcome they have looked at is a percentage of time of sensor glucose concentration in the target range. So the AI extension question is explain the intended use of AI intervention in the context of the clinical pathway including its purpose and its intended users. So the intended use of AI was by this AI-based insulin clinical decision recommendation system. So the AI suggests what dosage of insulin to be given and what type of insulin to be given at what time period for the patient. That is the use of the intended AI. So they have mentioned it in the study. So third question is a trial design, whether they have described the trial design and the allocation ratio, and also whether there was any important changes to the methods after trial commencement. So they have designed this study as a multi-center randomized control trial done in 3 medical centers in China. And eligible patients are randomly allocated to 2 groups at a ratio of 1:1. So one of the groups received after randomization, one of the groups received an intervention group, which has got an AA-based insulin delivery system, which will give the dosage recommendation. Then the clinician will review that AA-based recommendation in their mobile phone with the interface, and then they will decide whether to accept or reject. And if they accept it, that will be used for used on the patient. And there's a control group, whether there's a conventional method which is followed based on just a senior physician review. They decides what insulin dosage to be given, and it is used in the patient. So these are the 2 groups they have used, and they have done a 1:1 randomization. And they had done this trial. Trial duration was only for a period of 5 days. So only for a period of 5 days they've tried whether this group is actually better than that group, or whether this group is non-inferior to the senior physician group. And they did not have any changes after the trial commencement, which they mentioned in the study article. So the fourth one is the participants, eligibility criteria for the participants. So the AA extension involves whether there was any inclusion exclusion criteria at the level of participants when the participants were selected. So their participants were all patients with type 2 diabetes mellitus, more than 18 years of age, treated with a diet alone or any combinations of anti-diabetic agents or insulin, with an HbA1c ranging from 7 to 11%. So the exclusion criteria were patients with diabetic complications, BMI more than 45, women who are pregnant or breastfeeding, subjects with severe cardiac, hepatic, renal diseases, or patients with severe edema, infections, or peripheral circulation disorders, who are planned for surgery during hospitalization and who cannot comply with the protocol. So exclusion criteria had actually excluded patients with any complications of diabetes, and also patients who are sick patients who had severe cardiac, hepatic, or renal diseases. They were actually excluded. So most of the patients were relatively healthier patients, but they had HbA1c in the range of 7 to 11. And they had a screening period of less than 2 weeks. During the time they had screened the patients and assessed for eligibility. And they had a run-in period where they had included the patients, and then they had told the senior physicians to decide what insulin is needed for them for 1 day. That's for 24 hours. And that data was fed into the insulin delivery system. And then there was an intervention period where one group had the intervention with the senior physician whether accepting or rejecting, and the other group which had only had the senior physician deciding what insulin dosages to be given. And so the input data, so the second question in the Consort-Ai extension is whether there was any inclusion exclusion criteria at the level of input data. So they have not explicitly mentioned whether there was any exclusion criteria at the level of input data. However, their input data included capillary blood glucose measurements fed by the nursing staff. So this is an example of how they had used the model. Like for every day from 25/8/2020 for a period of 4 days, the blood glucose levels were checked at different levels, different time periods: morning 6 a.m., 8:30 a.m., 10:30 a.m., 1:30 p.m., 4:30 p.m. So every day the glucose measurements were done, and these were the previous data which is fed into the machine or the insulin delivery AI system. And based on this measurements which is fed by the nursing staff, the AI will suggest a insulin dosage titration for the next 24 hours. Like here they say insulin aspart to be given 30 units pre-dinner and 27 units tomorrow to be given. So like that they will give the recommendation based on the previous data which is fed to the system. So it also included details from the electronic hospital records and also insulin doses prescribed during the run-in period and previous insulin regimens and dosages. And the next question is, describe how the AI intervention was integrated into the setting, including any on-site or off-site requirements. So they said that this AI system was automatically embedded into the hospital information system, and the insulin recommendation were displayed to the clinician facing interface. And there was no offsite requirements which was used during the study period. However, the participating physicians and the staff underwent training on usage of the AI system before they had started the study. So this is the workflow of this AI system which they have given in the article. So there is the capillary blood glucose measurements. The electronic hospital records are fed into the system. Then they made the structured data set. Patient-specific features were also given, and which went into the AI model, and then insulin dosage was given to the physician. Now the fifth question is whether what version of the AI algorithm was used. So regarding what version which was used, so this AI system was previously developed and validated by the study team, and it has been mentioned in a previous study which said there was a real-time artificial intelligence assisted insulin dosage titrate system for glucose control. So in this study, in this previous study, they have mentioned that multiple machine learning models were analyzed, which included XGBoost, support vector machine, neural networks. These are all different AI models which can be used for generating an AI-based system, but they have not explicitly mentioned what is the final model that they've arrived at. They've only mentioned that it is an artificial intelligence-based insulin clinical decision support system, and describe how the input data were acquired and selected for the AI intervention. So like I've previously mentioned, the input data involved all these electronic hospital record previous insulin recommendations and this capillary blood glucose measurements by the nursing staff. Now the next question is describe how poor quality or unavailable input data were assessed and handled. So they did not mention in the study when one of the values were not available, how that unavailable input data handling was actually they dealt with. That is not explicitly mentioned in the study. Specify whether the human AI interaction in the handling of the input data and what level of expertise was required of users. So they've said that they have trained the hospital staff and the physician prior to starting the study. And the AI interaction was mainly, human AI interaction was mainly by the nursing staff uploading the capillary blood glucose measurement to the AI system, and also finally the recommendation given by the AI to the senior physicians in the hospital, which they finally decide to use it or not. And the output of the AI intervention was that insulin dosage recommendation for the next subsequent 24 hours, including what insulin to be used and what dosage to be used. That was a specific output of the AI intervention. Now explain how AI's interventions output contributed to decision making or other elements of clinical practice. So the physician reviewed the recommendation and decided whether to accept or reject. So this might tell us that maybe the physician decided to reject most of it, but they also mentioned that around 98.9% of AI recommendations were actually adopted by the physician. So it was completely an AI-based recommendation which they had followed during the study in the intervention group actually. So outcomes completely define pre-specified primary and secondary outcomes, including how and when they were assessed. So primary outcome they have mentioned was the proportion of time in target blood glucose range, which is from 70 to 180 milligram per deciliter. So this they are measured by a continuous glucose monitoring system. So every patient had a continuous glucose monitoring system. However, this was only used for checking the outcome, not the value by the continuous glucose monitoring system was not used by the AI for deciding what insulin dosage is to be given. That was mainly by the capillary blood glucose, which was uploaded by the nursing staff. And secondary outcome they have looked at was the amount of time the glucose levels are more than 250 or less than 54, mean sensor glucose concentration, glucose variability, and multiple secondary outcomes they have looked at. Now, sample size, according to the previous study which I had mentioned, they have found out that the mean time in range was 80%, with the non-inferiority margin, which they have assumed to be 6 percentage points to choose the difference between the groups. So they've calculated total sample size of 142 with a dropout rate of at least 10%, with a power of 80%, with a one-sided alpha of 0.025. And they did not plan any stoppage guidelines or interim analysis. So ideally, they should have planned the stoppage guidelines, which every trial they should have mentioned in their supplementary protocol or in the main study, but they had not mentioned any stoppage guidelines. So they've only mentioned if the patient develops any adverse events, the trial people will decide whether to terminate the study for only that patient, but they've not mentioned any stoppage guidelines. Now, sequence generation methods used to generate the random allocation sequence. They mentioned that the random allocation sequence was generated by an independent qualified statistician. However, how it was generated, this random sequence, they are not mentioned in the study. And type of randomization, they have used a block randomization using variable block size of 4 to 6. And they have concealed the allocation with sealed opaque envelopes. And who generated the random allocation sequence? It was by the statistician. And who assigned the participants to the intervention? Implementation enrolling was by the research staff. And who was blinded to the intervention? So blinding, participants were blinded, research staff who collected the outcomes were blinded, and outcome adjudicators were blinded. And statistical methods used to compare primary and secondary groups. So they have done an intention to treat analysis in this study. However, when we look at a non-inferiority trial, you should ideally do a per protocol analysis rather than an intention to treat. So they have, in the original article which they have published, they have given the intention to treat analysis. However, in the supplementary table, they have given the per protocol analysis also. So I'll be dealing with that. Yeah. Yeah. So what he was saying is we should do both per protocol and intention to treat in any RCTs. But as when we are critically appraising a study, if it's a non-inferiority trial, we should look at the per protocol results of it, not the intention to treat analysis of it. And methods for addition. So what statistical methods they have used? They have used a linear mixed effect regression model. So this is a model which is generally used when there is continuous outcomes in which we can use both random and fixed effects together to analyze the continuous outcome results. So I've checked the trial protocol and supplementary tables, but still they have not mentioned what the how they generated the random sequence allocation. Now, participant flow diagram, they have a participant flow diagram where they have assessed 305 patients were assessed for eligibility and 149 were enrolled into the run-in phase and 149 were randomized, 75 to the AA-based insulin group and 74 to the physician group. And there was around 9.3% loss to follow-up in the intervention arm and 8.1% in the control arm. And they have done this intention to treat analysis. So everyone was included in the primary analysis in the final outcome. Now recruitment, whether they have any dates defining the periods of recruitment and follow-up. So they have mentioned that the rate of recruitment was between October 1, 2021 and September 8, 2022. And why the trial was ended or stopped. So the trial was not stopped prematurely. They have mentioned in the article. And table showing baseline demography and clinical characteristics. So they have mentioned a baseline table where most of the patients were at the age more than 60 years of age, and male and female were equal proportion, and most of them had a duration of diabetes of at least 13 to 15 years. So most of them was diabetic for so many years. That's why most of them were on insulin by that time when they were included in the study. So these question does not have any A extension separate to it. This is just the consort questions which I'm talking about right now. So next is for each group, number of participants which were included. All participants are included in the denominator of the analysis. So what they are mentioning is whether they had done an intention to treat analysis or not. So they had done an intention to treat analysis by the originally assigned groups, and all patients who were randomized were included as denominator in the analysis. Now, outcomes and estimation. Whether they have given primary, secondary outcomes and results for each group. So I'll be talking about mainly the primary outcome. So this is the intention to treat analysis they have done. So that's why the numbers are 75 and 74 in each groups. So in this 70 to 180 was the time in target range, the percentage they've looked at. So they found out that 76.4% of the people in the AA-based insulin group had time in target range as opposed to 73% in the physician group. So they have got a point estimate as the treatment difference is 2.7. So they have got at least 2.7% estimated treatment difference, which is actually favoring the AA-based system. They have actually assumed a non-inferiority margin of -6, but the confidence interval is also from minus 2.7 to 8 actually, which is not very precise, which is crossing the line of null effect, but still they did not cross the non-inferiority margin by the intention to treat analysis. Now going on to per protocol also, in the AI-based group, it was 76.1% of the patients had time in target range and 73.9% in the physician group. So when we plot it in a non-inferiority graph, you can see that this is the non-inferiority margin, which is minus 6, and this is the line of no effect, which is 0, and this is their point estimate, which is 2.2, and with the confidence interval from minus 3.4 to 7.8, which is still within the non-inferiority margin. So in this trial, they've said that the artificial intelligence based system is actually non-inferior to the physician guided insulin titration system, or maybe it is equal also, we can say, because it's on both the sides and it's more towards the right side also. Yeah, if it crosses the margin, then we can't say it is non-inferior. Cross the line of noise. Yeah.
You have a negative margin.
Yeah.
If it's on completely on the other side, can't assume superiority unless the study is powered.
Yeah. So the non-inferiority margin, their value is actually within the non-inferiority margin. So based on this study, they have said that it is definitely non-inferior to the senior physician guided insulin delivery. Now, ancillary analysis, any other analysis they have performed, they have not performed any other subgroup analysis in this study. And harms, whether they have reported all important harms and unintended effects. So the main harms which they have reported is the hyperglycemia and hypoglycemia, which is sugar levels more than 360 or less than 54. Even that also they have mentioned that it was more in the physician group compared to the artificial intelligence based insulin recommendation system. And there was an AI extension in this, which is any of the analysis of performance errors they have reported or documented. So this they had not really mentioned in the study. There was no separate analysis on performance errors and how there were no details on how errors also could be identified. But what I understood is probably it was because that the recommendation was reviewed again by the physician during rounds, and then only it was accepted. And probably that was one of the reasons why they had not mentioned any analysis on performance errors. But this was one thing which they should have mentioned in the study article. Now limitations, whether they've given the limitation, generalizability or interpretation. So this is their limitation, generalizability or interpretation of the study article. So the limitations they have given us, it was done in all Chinese hospitals, and the duration of the study period is only 5 days. So it might not reflect the long-term outcomes in glycemic control or long-term outcomes of diabetes itself. And setting was only endocrinology wards. It was not the general population that they've looked at. It was only the endocrinology ward patient they've looked at. So they have also mentioned there could be a lack of generalizability because of different ethnicity of the patient population. And their interpretation is actually consistent with whatever the results they have actually got in the study article. Now registration, so they've registered with clinicaltrials.gov, and then this is the identifier, and trial protocol is available in the supplement. And the funding, they had got 2 grants by which they funded this study, and there was no role for the funder in the design or conduct of the study. This last extension is state whether and how the AI intervention or its code can be accessed, including any restriction to access or reuse. So this they have not given in the study. So this is something which they should ideally provide in the study, that whether other people can actually access this AI intervention or its code can be accessed. So these details are actually not provided in the article or in the supplementary appendix, and no details about whether this is actually licensed or accessibility is also not mentioned in the study. So overall, looking at, they have followed most of the guidelines which they should have followed while reporting an RCT using an AI. However, few things which they have not done. So probably it was because that the study was started during 2020, where 2019 only this AI reporting guidelines had come into. So going on to my case scenario, I would consider using this AI-based insulin delivery system because it is something which is actually definitely non-inferior to the senior physicians recommending the insulin for the patients, and definitely less staffing is required. The only thing is whether the cost of incorporating this into the hospital system and the software required to incorporate is the only problem which we need to look at. But otherwise, seems to be a really good way to implement into a hospital system. So this is I've just put up only the extensions of the Consort-Ai. So these are the 14 items which had come in 2019 as an extension when AI is used in a randomized control trial for reporting. Thank you.